Okay, so you sent over that chapter 41 on oxygenation. Really interesting stuff.
Yeah, it's pretty comprehensive.
It really is. And we've been, digging deep into it. The idea here for everyone listening is basically to pull out the most crucial bits, the fascinating
Right,
insights.
to give a clear picture of how our bodies get and use oxygen.
Exactly, without getting bogged down in it like super technical jargon, because this chapter, wow, it covers a lot.
From basic breathing mechanics all the way to, serious medical interventions.
Totally. And you know what jumped out at me right away? The fact that breathing out, expiration, is passive.
Hmm.
Your body just relaxes. That's kind of wild, isn't it?
It really is, and it perfectly sets the stage for understanding the mechanics.
Okay, so let's unpack this.
Well, as the chapter explains, it's all driven by pressure differences, moving air in and out.
Pressure, right. So breathing in, inspiration, that's the active part.
That's the active part. Your diaphragm, your external intercostal muscles, they actually contract.
They pull downwards and outwards.
Yeah, expanding the chest cavity. And this action creates what's called negative intrapleural pressure.
Negative pressure,
Hmm.
meaning lower than the air pressure outside.
Exactly. Lower than the atmospheric pressure, which is about 760 millimeter Hg at sea level.
Mm.
Think of it like creating a slight vacuum inside your chest.
So the air just naturally flows in to equalize it.
Precisely.
Yeah.
And what's interesting is that this negative pressure is always there, to some extent. It helps keep the lungs from collapsing.
Ah, okay. And the chapter mentioned the work of breathing, the WOB.
Right. Ideally, it should be easy, quiet, effortless, basically.
But when it becomes labored, that's a sign something's up.
Definitely. Which brings us naturally to lung volumes, understanding those different amounts of air.
Yeah, I found those definitions super helpful, like tidal volume, TV.
Your normal, everyday breath.
Yeah, about 500 milliliters, the chapter says. Pretty straightforward.
Hmm.
But then residual volume, RV, that's the air left even after you breathe out as hard as you possibly can.
That's the one. Around 1,200 milliliters. It stays in there.
That really stuck with me. Why is that so important?
Well, think about it. That residual volume, that bit of air left in the alveoli, the tiny air sacs,
Yeah.
it's what prevents them from completely collapsing on themselves.
Oh, right. Prevents atelectasis? Was that the term?
Exactly. Atelectasis.
Mm.
It's like trying to blow up a balloon much easier if there's already a little air inside, rather than it being totally flat and stuck together.
Makes sense. And then there was forced vital capacity, FVC.
Right. That's the maximum amount of air you can forcefully exhale after taking the deepest possible breath in.
Which is quite a lot, right? Like 4,000 to 5,000 milliliters in healthy adults.
Yeah, in that ballpark. And it's a really key measurement in pulmonary function tests.
For checking lung health, like for asthma or COPD.
Precisely. It helps assess how well the lungs are functioning, how much air they can actually move.
Okay, so we've got air moving because of pressure and different volumes of air, but what's happening down at the tiny air sac level, the alveoli? That's where surfactant comes in.
Absolutely crucial stuff. Surfactant. It's this substance that lines the alveoli.
And it manages surface tension. What does that mean exactly?
Well, imagine the inner surface of the alveoli is moist. Water molecules naturally want to stick together, creating surface tension.
Which would make the little sacs want to collapse.
Exactly. Surfactant gets in the way of that sticking. It reduces the surface tension, keeps the alveoli open and ready for gas exchange, oxygen in, CO2 out.
Without enough surfactant, they'd collapse. Atelectasis again.
You got it. Think about premature babies. Sometimes they don't produce enough surfactant yet, which is why they can have breathing problems.
Right, okay. And related to this, the chapter talks about lung compliance.
Yeah, compliance is basically how stretchy the lungs are, how easily they expand.
But it's not always good to be too stretchy, is it? Like in emphysema.
That's a great point. In emphysema, compliance is actually increased. The lungs stretch easily, but they lose their elastic recoil. They don't snap back well.
Making it hard to breathe out.
Right. And on the flip side, you can have decreased compliance.
When the lungs are too stiff.
Yeah, like with pulmonary edema fluid in the lungs or fibrosis, which is scarring, even things restricting chest movement, like severe scoliosis or kyphosis, or even fractured ribs.
Makes it harder to take a deep breath in.
Definitely. It takes more effort. Seems like a delicate balance,
It really does. And then there's the flip side of the coin, airway resistance.
which is pretty much what it sounds like. Resistance to airflow in the airways.
So narrower airways mean higher resistance.
Exactly. Think asthma, where the airways constrict, or inflammation and swelling like tracheal edema. It's harder for air to get through.
Okay, so if you have decreased compliance, meaning stiff lungs, or increased airway resistance.
Both of those lead to that increased work of breathing, the WOB we mentioned,
Your body has to work harder, use more energy, just for the simple act of breathing.
which, as the chapter highlights, is a huge issue in conditions like COPD, chronic obstructive pulmonary disease.
Yeah, COPD. The chapter explained it as like a double whammy, right?
Yeah.
You've got increased airway resistance and the lungs lose their elasticity.
Precisely. So air flows in, okay, maybe, but it gets trapped. It's hard to exhale fully.
Leading to hyperinflation, lungs getting overfilled.
Exactly. Hyperinflation makes breathing very labored, very inefficient.
And it's not just COPD, is it? Other conditions too.
Oh, yeah. Asthma, pneumonia, pulmonary fibrosis, pulmonary edema. They all mess with resistance or compliance or gas exchange itself. All roads lead to making breathing harder work.
So what happens physiologically when breathing becomes that difficult? The body has to compensate somehow.
It does. And that's when you start seeing the recruitment of accessory muscles.
Muscles not normally used for quiet breathing, like in the neck and shoulder.
Exactly. Neck muscles, shoulder muscles, even some chest muscles. When you see someone visibly using those muscles just to breathe.
That's a clear sign of respiratory distress.
Definitely. And using them long term is really inefficient, burns a lot of energy,
Mm-hmm.
and can lead to muscle fatigue,
Right.
eventually even respiratory failure.
Wow. And the chapter listed those visual cues to look for.
Yeah, things like nasal flaring and the nostrils widening.
And retractions where you see the skin pulling in between the ribs or above the collarbones.
Hmm. Changes in breathing rate and pattern, too. Fast breathing, shallow breathing.
Even facial expressions, skin color, that bluish tint, cyanosis.
And of course, a drop in their oxygen saturation, the SpO2 level, it paints a pretty clear picture of someone struggling.
But it's not always a problem originating directly in the lungs, right? The chapter mentioned other factors.
That's a key point. Our bodies are so interconnected, the chapter groups them nicely. You have respiratory disorders themselves, obviously.
Like breathing too fast or too slow, hypoventilation or
Yeah.
hypoxia, low oxygen.
Right. But then you have cardiac disorders, heart problems.
How does the heart affect breathing?
Well, if the heart isn't pumping blood effectively, it can't deliver oxygen properly, even if the lungs are getting it in.
Ah, okay. So things like electrical conduction problems in the heart, valve issues.
Myocardial hypoxia, lack of oxygen to the heart muscle itself. Peripheral hypoxia, lack of oxygen out in the tissues. Or cardiomyopathy, a weakened heart muscle.
All impact oxygen delivery. Makes sense.
And then there are sort of other factors. Anemia, for instance.
Fewer red blood cells means less oxygen carrying capacity.
Exactly. Or simply breathing air with less oxygen, like at high altitude.
Or when your body just needs more oxygen, like with a fever, increased metabolic demand.
Precisely. And then anything that physically restricts the chest wall movement.
Right, that list was long. Pregnancy, obesity, certain neuromuscular diseases.
Musculoskeletal problems, trauma to the chest, even alterations in the central nervous system that control breathing.
Basically anything that stops the chest cage from expanding properly.
Limits your ability to take a good deep breath.
And the chapter also touched on the long-term effects of chronic lung disease.
Yeah, like that characteristic barrel chest you sometimes see.
In COPD or cystic fibrosis, why does that happen?
It's thought to be from the constant overuse of those accessory muscles and also the lungs being chronically hyperinflated, trapping air.
And the classic symptoms show up.
Dyspnea,
Dyspnea, shortness of breath,
typnea,
rapid breathing,
hypoxemia,
low oxygen in the blood,
and maybe hypercapnia.
high carbon dioxide in the blood. The chapter even breaks down the suffixes. Techniocapnia for CO2, technia for blood oxygen, and oxia for the general state of oxygenation. Helpful distinctions.
Very helpful. And while all this is going on, the brain is kind of the master controller, isn't it?
Absolutely. The brainstem, specifically, is constantly monitoring oxygen and CO2 levels and adjusting our breathing rate and depth without us even thinking about it.
Amazing. Then, shifting gears a bit, the chapter mentioned lung volumes again, but in relation to body size and age.
Yeah, just some general correlations. Taller people tend to have larger lung volumes. Makes intuitive sense.
Bigger frame, bigger lungs generally. And it also notes that our lung volume typically peaks somewhere between, say, 19 and 40 years old.
And then gradually declines after that. Ugh.
Yeah, a natural part of aging, unfortunately.
Yeah.
And on average, males tend to have slightly larger lung volumes than females, just biological differences.
Okay. So the lungs do the gas exchange, get the oxygen in, but then it needs to get around the body. That's the blood's job, driven by the heart.
Exactly. Pulmonary circulation is key here.
Blood flowing to the lungs and back.
Right. The chapter emphasizes the right ventricle's role. It pumps that deoxygenated blood into the pulmonary artery.
Which goes straight to the lungs to pick up fresh oxygen.
So the strength of that right ventricle is vital for getting blood to the lungs effectively.
And then there was that mnemonic for tracing blood flow through the heart. I liked that.
Some real teachers play perfect learning games like Bad Students Always Aim. It's a bit long, but
It works.
yeah.
It walks you through it. Superior and inferior vena cava bring blood in.
To the right atrium, through the tricuspid valve.
To the right ventricle, then through the pulmonic valve.
Into the pulmonary artery, off to the lungs.
Then back, oxygenated, via the pulmonary veins.
To the left atrium, through the mitral valve.
To the left ventricle, the powerhouse, then through the aortic valve.
You're finally out the aorta to the rest of the body. Phew.
Quite the journey for a red blood cell. And the chapter mentioned cardiac output, how much blood the heart pumps.
Yeah, normally around 4 to 8 liters per minute at rest, which is quite impressive when you think about it.
Well, that's a lot of flow. And the formula was
Cardiac output, CO, equals stroke volume, SV times heart rate, HR.
stroke volume being the amount per beat, heart rate being beats per minute.
Right. And factors affecting it include preload.
How much the ventricle stretches when it fills.
Yep, at the end of diastole. And afterload.
The resistance the heart has to pump against.
Exactly. The resistance the left ventricle faces pushing blood into the aorta. Plus, myocardial contractility, how strongly the heart muscle itself squeezes.
And heart rate matters too, right? But not just faster is better.
No, definitely not. If the heart rate gets too fast, say over 160 beats per minute, there isn't enough time between beats for the ventricles to fill properly.
So stroke volume goes down.
And therefore, cardiac output goes down, even though the heart is beating rapidly. Yeah. Less efficient.
Got it. And underpinning all this mechanical pumping is the heart's electrical system.
The natural pacemaker.
Yeah.
Starts at the SA node, the sinoatrial node,
Sends the signal across the atria
then hits the AV node, the atrioventricular node, pauses slightly.
to let the ventricles fail.
Right. Then down the bundle of his, through the bundle branches in the septum,
And finally out to the Purkinje fibers in the ventricle walls.
causing that coordinated contraction, pumping blood effectively. It's this electrical sequence that ensures oxygenated blood gets where it needs to go.
Okay, so that's the normal system. What happens when someone isn't getting enough oxygen and needs help? That's where the delivery systems come in.
Right. The chapter gives a good rundown, starting with the simpler, low-flow systems.
Like the nasal cannula, the little prongs in the nose.
Exactly. Delivers oxygen at about 1 to 6 liters per minute. Simple, common, fairly comfortable.
Downsides. Can dry out your nose.
Yeah, and not super effective if you're a mouth breather or have blocked nasal passages. Then there's the simple face mask.
Covers nose and mouth, higher flow.
A bit higher, maybe 6 to 12 liters per minute,
Yeah.
often used for shorter periods.
And then those masks with the bags attached, partial rebreather and non-rebreather.
Right. They have a reservoir bag that fills with oxygen, allowing for higher concentrations to be delivered, maybe 10 to 15 liters per minute flow, but they're still generally considered low-flow delivery systems in terms of precision.
Okay. Then what about high flow options?
Well, you've got the high-flow nasal cannula, which can blast oxygen up to 60 liters per minute, often heated and humidified.
That's more powerful.
Yeah. And the Venturi mask, that one's interesting.
Why is that?
It uses special adapters to deliver a very precise concentration of oxygen, a specific FiO2, often with humidity added. More control.
Okay. And then we get into non-invasive ventilation, CPAP and BiPAP.
Continuous positive airway pressure and bilevel positive airway pressure. They deliver pressurized air, often with supplemental oxygen mixed in, anywhere from room air, 21% up to 100%. They help keep airways open.
Without needing a breathing tube.
Right. And then for manual ventilation, there's the ambu bag, usually connected to an endotracheal tube or tracheostomy tube.
So quite a range of support levels available.
Definitely. And the chapter makes a really critical point about using oxygen with COPD patients.
Ah, yes. You have to be careful, right? Why is that?
Because many people with chronic COPD have gotten used to slightly lower oxygen levels and potentially higher carbon dioxide levels. Their main drive to breathe might actually be triggered by low oxygen, not high CO2 like in most people.
So if you give them too much oxygen.
You could potentially knock out that hypoxic drive, causing them to breathe less, retain even more CO2, and develop respiratory acidosis. It's a risk.
So the goal isn't necessarily 100% oxygen saturation for them?
Generally, no.
Yeah.
For many COPD patients on low-flow oxygen, like a nasal cannula, the target's PO2 might be lower, maybe 88, 92%.
Keep them safe, but don't overdo it.
Exactly. Sometimes, if more precise control is needed, a high-flow system like a Venturi mask might be used, or in acute situations, non-invasive ventilation like BiPAP can provide support.
So it really requires careful monitoring, blood gases, oxygen levels, how they're breathing.
Constant vigilance. Understanding that hypercapnic drive issue is key.
Okay, so we've covered getting oxygen in, delivering extra oxygen. What about maintaining lung health and promoting expansion?
Simple things can make a big difference, like ambulation.
Just getting up and walking around.
Yeah. It counteracts so many complications of being immobile, especially pulmonary ones like pneumonia or atelectasis.
And positioning, too, like sitting up.
The semi-Fowler's position, head of the bed raised about 45 degrees. It takes pressure off the diaphragm, makes breathing easier. Basic, but effective.
And then there's that gadget, the incentive spirometer.
Yes. That simple, inexpensive plastic device.
How does that actually help?
Well, the chapter lays out the technique. Sit upright, breathe out fully.
Then seal your lips around the mouthpiece and inhale slowly and deeply, trying to raise the piston or balls.
Right. Hold that breath for a few seconds, maybe 3 to 5.
Then exhale slowly and repeat, like 10 times an hour.
Ideally, yeah, while awake. And maybe a little cough afterwards to clear secretions.
What's the benefit of doing all that?
It encourages those slow, deep breaths that reinflate collapsed alveoli, preventing atelectasis. It promotes overall lung expansion, improves oxygenation, and helps mobilize mucus.
So really useful after surgery or for people stuck in bed.
Exactly. Post-op patients, immobile individuals, the elderly, people after chest trauma, they often benefit significantly. It's simple preventative medicine.
Good stuff. And the chapter also looped back to non-invasive ventilation, CPAP, BPAP again.
Right, mentioning them not just for oxygen delivery, but specifically for maintaining that positive airway pressure to keep alveoli open and improve ventilation, sometimes avoiding the need for intubation.
But sometimes intubation is needed. Invasive mechanical ventilation.
Yes, when someone really can't maintain adequate gas exchange on their own. It requires an artificial airway, like an endotracheal ET tube, or a tracheostomy.
It's life support, essentially, takes over the work of breathing.
It supports gas exchange, can increase lung volume, and significantly reduces the patient's own work of breathing. The chapter mentions a few common modes.
Like assist control, AC.
Yeah, where the ventilator delivers a set breath volume or pressure every time, whether the patient triggers it or the machine times it out.
And SIMV. Synchronized intermittent mandatory ventilation.
That one delivers a set number of mandatory breaths, but allows the patient to take their own spontaneous breaths in between.
A bit more flexible. And pressure support, PSV.
That provides a boost of pressure during the patient's own spontaneous breaths, making it easier for them to inhale, often used alongside SIMV or during weaning.
But ventilation isn't without risks, right? The chapter highlighted VAP.
Ventilator-associated pneumonia, yes, a major complication, because that artificial airway bypasses all the natural filtering and defense mechanisms of the upper airway.
Bacteria have a more direct route to the lungs.
Exactly. So meticulous oral care and other preventative bundles are crucial.
Okay. Now, shifting topics slightly, but still related to the chest cavity, chest tubes. When are those used?
Typically after chest surgery or trauma, if there's air or fluid collected in the pleural space, that space between the lung and the chest wall.
So for a pneumothorax, air in the space?
Right. Or hemothorax, blood in the space. Or other fluid like pleural effusion.
And the tube is to drain that out.
Exactly. Removing the air or fluid allows the collapsed lung underneath to re-expand.
Makes sense. What are the key things to manage with chest tubes?
The chapter stresses keeping the drainage system closed and always below the level of the patient's chest. Gravity is your friend.
Okay, what about the chambers on the drainage unit?
You monitor the suction-controlled chamber, often looking for gentle, steady bubbling if suction is applied, and the water-sealed chamber.
What are you looking for there?
You check the water level, and you watch for fluctuation or tidling. The water level should rise and fall slightly with the patient's breathing.
What if it bubbles constantly?
Constant or even intermittent bubbling in the water-sealed chamber usually indicates an air leak somewhere. Could be from the patient or the tubing system. Needs investigation.
Gotcha. And you watch the drainage itself. Amount, color.
Absolutely. Report any sudden changes or unexpected large amounts. Also, ensure the tubing isn't kinked or looped. Encourage repositioning and maybe even ambulation if allowed. Regular checks of breathing, tube site, everything.
And that critical point about clamping.
Right.
Sure.
Generally, never clamp a chest tube that's actively draining air or fluid unless you have a specific medical order and reason.
Why not?
because if air is still leaking into the pleural space and it can't escape through the tube, it can build up rapidly and cause a tension, pneumothorax, a life-threatening emergency, where pressure crushes the lung and heart.
Okay, very important safety point. Don't clamp without orders. Last big topic. Suctioning.
Yeah, for when patients can't clear their own airway secretions effectively by coughing.
What's the key technique?
The absolute main thing is applying negative pressure suction only during withdrawal of the catheter, never while inserting it.
And not too much pressure, right? Less than 120 millimeter Hg.
Generally, yes. Keep the procedure quick, 10 to 15 seconds total per pass. Use the smallest catheter that works. Apply suction intermittently while twisting and withdrawing.
Okay. And there are different types depending on where you're suctioning.
Right. Oropharyngeal, mouth back of throat, and nasopharyngeal, nose back of throat, are usually clean techniques, not sterile. Often for patients who can cough but can't quite clear things out.
And then suctioning lower down.
Orotracheal, mouth down trachea, and nasotracheal, nose down trachea, require sterile technique because you're entering the lower airway.
And tracheal suctioning. Through a track or ET tube?
Always sterile technique for that.
Yeah.
You're bypassing all upper airway defenses.
And the chapter mentioned open versus closed suctioning.
Yeah, open suctioning uses a new sterile catheter kit each time. Closed suctioning uses a catheter enclosed in a plastic sheath that stays connected to the ventilator circuit, allowing suctioning without disconnecting the patient, often used in ICUs.
And prepping the patient beforehand is important too, I imagine. Hyperoxygenating sometimes.
Yes, often pre-oxygenating the patient is recommended, especially before suctioning an artificial airway, to prevent oxygen levels from dropping too low during the procedure.
Wow. Okay. That was a lot, but really comprehensive.
It really covers the journey of oxygen.
So as you can see, you, listening, that chapter really gives you the full picture. From how we take a simple breath, those pressure changes, the lung volumes,
To the crucial role of surfactant, how easily lungs stretch, how easily air flows,
how the heart pumps that oxygenated blood everywhere.
and then all the ways we can support that process when needed. Oxygen therapy, ventilation, chest tubes, suctioning.
It really builds that foundational understanding, how intricate it all is.
It truly does. And bringing it all together, you just see how vital the connection is between the respiratory system, the cardiovascular system, and just our overall well-being.
Definitely. And considering all those factors we talked about, diseases, lifestyle, environment that can impact breathing, it makes you think, doesn't it? Like, what are some of those everyday habits or exposures, things we might not even notice, that could be subtly affecting our own respiratory health over time?
That's a really good question to ponder. Food for thought.
It really is.
Yeah.
But ultimately, it's just kind of awe-inspiring, the complexity, the resilience of our bodies, keeping everything going breath by breath.
Absolutely. Quite remarkable.